I'll be covering etiopathogenesis and staging of type 1 diabetes and ADA recommendations on diagnostic criteria, investigation of suspected type 1 diabetes in newly diagnosed adult, ICPAD glycemic targets, diabetes self-management education and support or DSMES, monitoring of glucose levels, insulin therapy, hypoglycemia and its prevention, and recommendations for screening of complications and related conditions in pediatric type 1 diabetes. So as it has been already discussed, type 1 diabetes mellitus due to autoimmune beta cell destruction usually leading to absolute insulin deficiency and 15 per 1 lakh population in the world. And etiopathogenesis, as Professor Sanjeevi and Professor Lenmark have discussed, less common than type 2 diabetes. It has beta cell autoimmunity, environmental challenges, and genetic factors. Viral infection, genetic predisposition, and autoimmune inflammation play a vital role in the etiopathogenesis of type 1 diabetes. And the marked absolute insulin deficiency resulting from diminished beta cell mass leads to low serum insulin level and thereby the symptoms. We can divide type 1 diabetes occurring in 3 stages: stage 1, stage 2, and stage 3. And we'll look at beta cell autoimmunity, beta cell loss, dysglycemia, and symptoms. In stage 1, there is beta cell autoimmunity. In 2 also autoimmunity, 3 also autoimmunity. Beta cell loss is present in all 3 stages. But when it comes to dysglycemia, in stage 1, there is no dysglycemia, and hyperglycemia in the stage 2 and stage 3. But if you look at the symptoms, stage 1 has no symptoms. Stage 2, there is also no symptom. And when the child reaches stage 3, there are symptoms of type 1 diabetes. So this takes, there are both stage 1 and stage 2 are in the pre-symptomatic type 1 diabetes, and whereas stage 3 is symptomatic diabetes. If you look at the age-specific rates of type 1 diabetes, you can see from 0 to 4 and 5 to 9, 10 to 14, 15 to 19, 20 to 24, and like that 30 to 34. And now the new concept of adult onset type 1 diabetes has come. So as Professor Lenmark was talking, you can see more of cases between 10 to 15 years of age, maybe from 5 to 15 years of age. This has been discussed by Sanjeevi, the histological examination of pancreatic tissue, and in type 1, in the 1 category, you find there is a massive mononuclear cell infiltration and around the pancreatic islets in 1 patient, that is a red arrows in the left side here. And here you can see less severe insulitis only involving dendritic cells in another patient, or white arrows. So what is the recommendation of ADA, the primary body for recommending treatment protocols in American Diabetes Association? And they recommend screening for pre-symptomatic type 1 diabetes using screening tests that detect autoantibodies to insulin, glutamic acid decarboxylase, islet antigen 2, or zinc transporter 8 is currently recommended in the setting of a research study, or can be considered an option for first-degree family members of a proband with type 1 diabetes. This is for research study, and development of and persistence of multiple islet autoantibodies is a risk factor for clinical diabetes and may serve as an indication for intervention in the setting of a clinical trial or screening for stage 2 type 1 diabetes. So these are all required things. So if you come directly to the staging, in stage 1, If you look at autoimmunity, there is normoglycemia and pre-symptomatic. There is multiple islet autoantibodies and no IgT or IgG. If you find islet antibodies, that to multiple without any IgT or IgG, then it is a case of type 1 diabetes stage 1. In the stage 2, there is autoimmunity, there is dysglycemia and pre-symptomatic there are multiple autoantibodies, both GAD, IA2 or IA, all those things are gene transporter, and dysglycemia is there like IFG or IgT. Fasting is between 100 to 125, 5.6 to 6.9 millimole. 2 hour is 140 to 199, and A1C is 5.7 to 6.4, which is also we discussed yesterday about the ANC values. In the stage 3, the characteristic is overt hypoglycemia. Hyperglycemia is frank and the symptoms are frank. There are clinical symptoms, diabetes by standard criteria, and autoantibodies might be absent. This is a very important thing. As Professor Landmark was telling, IA2, if it appears very soon, insulin dependence and type 1 diabetes will occur. But in GAD antibody, there is a lag phase. Maybe after 10 years, you find the GAD antibody, but not IA2. So autoantibodies might be present or might be absent. So what are the investigation of suspected type 1 diabetes in newly diagnosed adult type? We know the children, younger children, how to diagnose we know. But the new concept is adult type. They are misclassified as type 1 diabetes if the occurs in adult persons. Over 40% of those developing type 1 diabetes after the age of 30 years are initially treated as having type 2 diabetes. Rapid progression to insulin treatment within less than 3 years is strongly suggestive of type 1 diabetes at any age. The absence of autoantibodies does not exclude type 1 diabetes. And if you look at the algorithm quickly, adult with suspected type 1 diabetes, islet cell autoantibodies, islet cell antibody positive, it is type 1 diabetes straight. If it is not positive, you look at the age. And we continue. One group we diagnose as type 1 diabetes, in other we are doubtful. At the age, if it is less than 35 years age, we continue the diagnosis and we end at type 1 diabetes. If it is more than 36 years of age, usually we consider C-peptide. In all these, C-peptide is important, and if C-peptide is less than 200, it is type 1 diabetes, and if it is between 200 to 600 picomole, it is indeterminate, and if it is more than 600, then it is your type 2 diabetes. So there are two criteria: autoantibody marker positive, straight diabetes type 1, and otherwise C-peptide will discuss along with the age criteria. So glycemic targets for children, adolescents, and young adult with diabetes has been recommended by ICEPAT. Children, adolescent, and young adults pre-meal should be 70 to 130, after meal 90 to 180, bedtime 80 to 140, and A1C less than 7. And target blood glucose level of the diabetics should be maintained, but A1C target of 7% is recommended for persons who have access to analog insulin, advanced insulin delivery technology, and ability to regularly check blood glucose or use CGM. But higher H1C of 7.5 is also clinically acceptable in these children. Then what are the goals and aims of management of type 1 diabetes? HbA1c should be less than 7, and glucose management indicator also should be less than 7. Preprandial glucose should be 80 to 130. Postprandial will be less than 180. Time in range should be 70% or above and time below range should be less than 4% or less than 1% if the glucose level is less than 54. If glucose level is less than 70, then it is 4%, and if it is less than 54, it is 1%. And type above range and should be, if it is more than 180, it should be less than 25%, and if it is more than 250, it should be less than 5%. On an average, glycemic variability should be equal to or less than 36. So schematic management for new onset type 1 diabetes in adult, we will say type 1 in younger generation is well established. So in this case, type 1 diabetes self-management education and support, fundamental of nutrition, carbohydrate counting, and physical activity is to be taught. Then start glucose monitoring, like CGM is preferred in Western countries, but blood glucose monitoring is common in our country. Start insulin therapy, preferably multiple daily insulin dose, but other regimens including pump or hybrid closed loop technology can be started based on individual circumstances and affluence. You should prepare the patient for hyperglycemia and what to do, provide education on recognition, management, and prevention of hyperglycemia. Discuss when and how to measure ketone and provide method for ketone testing. And last is prepare for hypoglycemia. Teach principles for prevention and management of hypoglycemia, provide glucagon and education on how it should be used. Unless these things are there, it is very difficult. One of the most important thing of the management is diabetes self-management, education and support, DSMES. The objective of DSMES is to provide knowledge, skills, confidence to successfully self-manage diabetes. Culturally sensitive and developmentally appropriate individualized diabetes self-management education and support according to national standards or diagnosis, and routinely thereafter it should be used. Levels of DMS are there. Level 1, diabetes information, one-to-one advice. Level 2, ongoing learning that may be informed in such a group discussion. And level 3, structured education. There are already curriculum and those things can be taught. As you know, this is the center is the curriculum, pathophysiology of type 1, healthy eating thing, physical activity, preventing, detecting and treating acute complication. Like that, the curriculum is there to be followed. But at diagnosis, all newly diagnosed people with type 1 diabetes should receive DSMES and medical nutrition therapy. Ensure emotional health is addressed. Then annually or when not meeting treatment targets, review of knowledge, skills, psychosocial and behavioral outcomes, barriers and facilitators. Unexplained hypo or hypoglycemia should be explained. And when it comes to transitions in life, teenage and all those things, marriage, then age-related responsibilities for young adults should be educated. Initiation or intensification of insulin, new devices or technology should be introduced to these patients, and age-related changes, how they are affecting the management must be explained to them. And finally, when complications start developing, development of long-term complications and a need for any other drug or steroid or planning a pregnancy or pregnant woman, they all need to be clearly explained about how life should continue other than insulin therapy. So primary thing is monitoring of blood glucose, monitoring glucose levels multiple times daily. So we are doing 3 times, 4 times, sometimes 7 times, but 10 times can be done by glucometers on continuous glucose monitoring. Continuous glucose monitoring metrics used over the most recent 14 days. Last 14 days period, we study that and recommended to be used in conjunction with A1C whenever possible. A1C goal must be individualized and reassessed over time. An A1C less than 7 is appropriate for many children, but 7 to 7.5 in Indian setting, we find it is comfortable. And the methods are HbA1c, capillary blood glucose monitoring, continuous glucose monitoring, and ketone measurement are needed in managing this. So continuous glucose monitoring, Dr. Bansi Sabu has told in detail, and yesterday's technology session, we just want to know number of days for CGM device is 14 days. Time in percentage of time is active is 70% from 14 days. Mean glucose and glucose monitoring indexes, glycemic variability, and time above average, as I was discussing, should all be taken into consideration. And once the graph comes out, it comes in your computer or in the hard copy printed, you can see where the child is going above range and below range. And as I told, the below range criteria and above range criteria should be followed, and almost 70-73% should be in the time in range. So insulin therapy, we know it very well. People with type 1 diabetes should use regimens that mimic physiology as closely as possible, irrespective of the prescription. Injected insulin regimen, their flexibility, low risk of hypoglycemia, and higher cost. In that, if you see multiple daily insulin dose, multiple daily insulin with long-acting insulin analogs or rapid-acting insulin analog or ultra-rapid insulin analog, acting insulin analog, they are the best. They are flexible, low risk of hypoglycemia, and higher cost. But so to reduce economy, we can go for multiple dose with NPH, rapid acting analog, or ultra rapid acting analog. Is fairly good. Then next to that is NPH with short acting insulin, or 2 daily injection of NPH plus short acting insulin. So this is the basic rule. And secondly, most individuals with type 1 diabetes should be treated with multiple daily injections of prandial and basal insulin or continuous subcutaneous insulin infusion if the glucose is high. And in our wards, we treat them with this. Individuals with type 1 diabetes should use rapid-acting insulin analogs to reduce hypoglycemic shock. Greatest benefits seen with algorithm-driven automated basal insulin delivery, also known as hybrid closed-loop therapy, is also possible, but very few in India have started using it. Gradually, when the price comes down, it will come to the common use. So, regarding insulin delivery systems, automated insulin delivery systems should be offered for diabetes management to youth with type 1 diabetes who can use the device safely, either by themselves or by the caregivers. The choice of device should be made based on patient circumstances, which is very important. He can afford or not, desires and needs. 2 more slides. Hypoglycemia and its prevention. Hypoglycemia is the main limiting factor in the glycemic management of type 1 diabetes. Prevention needs structured diabetes education in flexible insulin therapy, informed support for active insulin dose self-adjustment, hypoglycemia avoidance, and motivational programs are of a very important issue, and the use of insulin analog regimens are associated with less hypoglycemia. But the hybrid closed loop system results in both improvement in TIR and reduction in time below range. We are waiting for that. And beta cell replacement therapy is also another choice, but not in the common use now. Severe diabetic chronic kidney disease, then you think of living donor kidney and simultaneous transplantation of pancreatic beta cells. And gradually, that is a severe metabolic complication. You can think of pancreatic transplantation alone or islet transplantation alone. So my last slide, to look for complications and related condition in pediatric type 1 diabetes. The recommendations are method, when to start and follow up. And the conditions are thyroid disease, celiac disease, hypertension, dyslipidemia, nephropathy, retinopathy, and neuropathy. In thyroid disease, thyroid stimulating hormone, consider antithyroglobulin and antithyroid peroxidase antibodies. You do it soon after the diagnosis, and every 1 to 2 years if thyroid antibody is negative, more often if symptoms develop or presence of thyroid antibodies. Regarding celiac disease, you have to do IgA, TTG. If total IgA normal, IgG, TTG, and deamidated gliadin antibodies if IgA is deficient. And you do it soon after the diagnosis if symptoms of celiac disease are there, and then within 2 years, and then at 5 years after diagnosis, sooner if symptoms develop. Regarding hypertension, blood pressure monitoring at diagnosis and with every visit. Dyslipidemia, you can lipid profile, non-fasting acceptable initially, subsequently you can go for fasting. Soon after diagnosis, preferably after glycemia has improved, and 2 years old. If LDL is 100 milligram per DL, repeat at 9 to 11 years old, and then if less than 100, every 3 years. And in nephropathy, we have discussed today, albumin to creatinine ratio, random sample acceptable initially, then puberty or more than 10 years old, whichever is earlier, and diabetes duration of 5 years, you should do this. If normal, annually. If abnormal, repeat with confirmation in 2 of 3 samples over 6 months. Follow up. Next is retinopathy, dilated fundoscopy or retinal photography, puberty or 11 years old, whichever is earlier, and diabetes duration of 3 to 5 years. If normal, every 2 years, consider less frequently every 4 years if A1C is less than 8. And last is neuropathy foot examination, foot pulses, pinprick, 10 gram monofilament sensation test, vibration, and ankle reflexes. You do it at puberty or more than 10 years old, whichever is earlier, and diabetes duration of 5 years. If normal, annually. So these are the indications and guidelines for diagnosing type 1 diabetes both in young and in young adult, and these are the parameters that we follow. Thank you. Thank you, Dr. Prasanna Kumar.